Well, I'm Cristina Valencia Sanchez. I am an autoimmune neurologist at the Mayo Clinic in Arizona. And actually, I'm going to be here just for a couple more weeks because I'm moving back to my home country, to Spain, in the end of this month. But I'm really happy to be here today, and thank you, Meg, for the invitation. I'm going to talk about complications of immune checkpoint inhibitor cancer immunotherapy. And then the second half, I will discuss some cases. I don't have any relevant disclosures for the talk today, and this is the outline of the talk. So first, we'll talk about central and peripheral nervous system immune-related adverse events triggered by immune checkpoint inhibitors. I will talk a little bit about the diagnostic and treatment approach of these neurological complications, and I will talk a little bit about the outcomes and the prognostic factors for patients with neurological immune-related adverse events. And after that, we will go through some cases. So first of all, the immune checkpoints are inhibitory signals that regulate the immune responses. They are important to maintain self-tolerance and to limit the immune cell expansion, and also to prevent autoimmunity. So the immune checkpoint inhibitors are monoclonal antibodies that are going to block those pathways that have inhibitory effects on the T cell activation. And therefore, what they do is that they enhance the antitumor immune responses by releasing the brakes of the immune system. These molecules have really revolutionized the treatment of many malignancies and have improved the survival of many malignancies. Every year, there are new indications for these medications. And this is the list of the currently approved agents we have. And based on their target, we call them anti-CTLA4, anti-PD-1, anti-PD-L1, and anti-LAG3. Because they enhance the immune responses, they may also trigger immune-related adverse events that can really affect any organ. And actually, sometimes multiple organs are affected at the same time. Most of these immune-related adverse events are mild and reversible. And the prevalence increases in those patients who receive combination therapy, who receive two of these drugs at the same time. The neurological immune-related adverse events have the highest mortality, along with the cardiological immune-related adverse events, and that's why it's really important to know about them. Although really the incidence of severe neurological immune-related adverse events is rare, between 1 to 1.5%, depending on the case series. They may coexist with other organ involvement. They typically appear within the 3 first months after starting treatment with immune checkpoint inhibitors, and they may affect any level of the neural axis, the central nervous system, the peripheral nervous system, and oftentimes they are multifocal. And the most common are actually the neuromuscular complications, although today I'm going to focus a little bit more on the central nervous system complications. There are some studies that have shown that the phenotypes of the neurological immune-related adverse events may be a little bit different depending on what type of drug we are using, and also on the cancer type. So for example, myositis and limbic encephalitis are more frequently reported after PD-1 or PD-L1 treatment, whereas meningitis and polyradicular neuropathy are more common after treatment with anti-CTLA4. Also, in patients with peripheral neuropathies and meningitis, it's more common that they would have melanoma as the tumor that is being treated, whereas in those patients with encephalitis, lung cancer is more frequent. In terms of what are the mechanisms that underlie these neurological immune-related adverse events, we are still learning about this, but we suspect there are two main mechanisms. The first one is cancer antigen-driven paraneoplastic syndromes. So high-risk paraneoplastic syndromes have been described after treatment with immune checkpoint inhibitors. And in those cases, what we think is that there is a shared autoantigen between the tumor and the neural tissue. So the antitumor immune response against the immune response against the tumor also is directed against the neural tissue, because they are sharing that antigen. And after immune checkpoint inhibitor treatment, because there is an enhanced T cell response, that contributes to the development of the paraneoplastic syndrome. They're also supporting also this mechanism. There are some studies that have shown that in patients who developed paraneoplastic syndromes after treatment with immune checkpoint inhibitors, in some of those cases, they were able to get blood that had been stored from these patients prior to treatment with immune checkpoint inhibitors. And they found that these patients already had some of those high-risk antibodies like MA2 or anti-Hu or ANA1 prior to the treatment with immune checkpoint inhibitors. So perhaps the treatment with immune checkpoint inhibitors was exacerbating that subclinical immune response. And then there is another mechanism which is thought to be related, for example, to those cases of demyelinating disease that occur after immune checkpoint inhibitor treatment. So in this case, the thought is that the immune checkpoint inhibitors are enhancing two independent pre-existing immune responses. One is directed against the tumor, and the other one is directed against the nervous system. And this was demonstrated on a case of a patient who had radiologically isolated syndromes, so asymptomatic demyelinated lesions in the brain before treatment with immune checkpoint inhibitors. And this patient transitioned to clinical multiple sclerosis after treatment with immune checkpoint inhibitors. And in this patient, they analyzed the CD4 and CD8 T cell repertoires in the tumor and the spinal fluid, and they were different. So that's why the thought is that those are two independent immune responses that are triggered by the immune checkpoint inhibitors. Now we're going to talk about the central nervous system complications. So one of the most common CNS complications is meningitis or meningoencephalitis, and this is a typical case. This was a 60-year-old female with metastatic melanoma who was treated with nivolumab, and 4 months later presented with severe headache, nausea, vomiting, and she also had some word finding difficulties and gait impairment. And on exam, she was somnolent, disoriented in time, had mild expressive aphasia, gait ataxia, did not have a fever. The MRI showed this kind of diffuse leptomeningeal enhancement on the post-contrast images. The spinal fluid showed pleocytosis with 34 white blood cells, mostly lymphocytes, and a high protein of 225. The infectious studies were negative. This patient was treated with oral prednisone, and the symptoms and the MRI abnormalities resolved. So this is the typical presentation of meningitis, meningoencephalitis. Patients with meningitis present mostly with meningeal signs, headache, nausea, vomiting, photophobia. When there is also involvement of the brain parenchyma, we call it meningoencephalitis, and those are patients who may also present with altered mental status. In these cases, sometimes there is also involvement of the cranial nerves and the nerve roots. The brain MRI may be normal or show meningeal enhancement, like in the case that I showed. It is frequent that this patient will have pleocytosis in the spinal fluid. When we test for antibodies, most of these cases are seronegative, although there are also some cases of anti-GFAP reported, and usually these patients respond very well to steroids with improvement or resolution of the symptoms. The next CNS complication is encephalitis, and this is a typical case, 62-year-old female with a small cell lung cancer treated with immune checkpoint inhibitors, and after 4 cycles developed confusion, shaking movements of the arms and the legs that were thought to be seizures, and steady gait. On exam, the patient was disoriented, had paraphasic errors, multidirectional nystagmus, bilateral upper and lower limb ataxia, so cerebellar signs. And the MRI showed hyperintensity in the medial temporal lobes. Spinal fluid showed mild pleocytosis and elevated protein. And this patient was found to be positive for ANA1 or anti-Hu in blood and spinal fluid. So paraneoplastic syndrome triggered by immune checkpoint inhibitors. The immune checkpoint inhibitor was discontinued. This patient was treated with IV steroids without improvement, then was transitioned to IV cyclophosphamide. And after a few cycles, she was transitioned to oral cyclophosphamide while she continued weekly steroids, but unfortunately continued to get worse neurologically. And eventually the small cell lung cancer progressed, and patient and family decided to transition to hospice. So these are patients that unfortunately have poor prognosis. So the encephalitis, these patients may present with focal syndromes, with limbic encephalitis, diencephalic involvement, brainstem involvement, cerebellar involvement. and they oftentimes mimic paraneoplastic syndromes. The abnormalities that we see in the brain MRI are consistent with the syndrome that they are presenting with, and oftentimes the spinal fluid is inflammatory with mild pleocytosis, and oftentimes we also find positive neural antibodies in the serum and spinal fluid. Recently, there was a study, a large case series that actually reported a group of patients who seem to have an encephalopathy that doesn't have a distinctive syndrome, and no clear inflammatory changes, but that there is really no alternative explanation. So these are patients who developed decreased level of consciousness, hyperthermia, myoclonus psychosis, seizures after treatment with immune checkpoint inhibitors, and that because no other cause was found, because there was a temporal association with immune checkpoint inhibitors, and some of them also had no neurological immune-related adverse events. These were thought to be immune-related encephalitis, and these patients have also poor prognosis. Another central nervous system complication is myelitis. So patients may present with transverse myelitis, which may be longitudinally extensive on the MRI. There are some cases of demyelinating MS lesions reported. Many times these patients with myelitis do not have specific antibodies, but there are cases of GFAP myelitis, aquaporin 4 positive, longitudinally extensive transmyelitis, MOG positive cases as well. And in some cases, it may mimic paraneoplastic syndromes with a progressive myelopathy, for example, in cases with CRIMP5. And now we're going to talk about the peripheral nervous system complications. So the first one is cranial neuropathies. The optic nerve may be involved, and also the cranial nerve 7, 8, and 6 are the most common. Sometimes it may be bilateral. Other cranial nerves, 3, 5, 9, have also been reported. Oftentimes, cranial nerve involvement presents also with meningitis. MRI may show enhancement of the affected nerves. The spinal fluid is frequently inflammatory, and these are also patients that typically respond well to steroids. With regards to neuropathies, the most commonly reported are the polyradicular neuropathies, oftentimes with GBS-like presentation, like an acute inflammatory demyelinating polyradicular neuropathy. They may also have cranial nerve involvement. Spinal fluid may show albuminocytologic dissociation, like in GBS. However, in these cases, pleocytosis is common. And they, in the MRI, we sometimes see enhancement of the chora equina nerve roots, like in this picture. And these patients also typically have good response to steroid treatment. Many other phenotypes of neuropathies have been reported. And oftentimes the question in these patients is because, some of these patients, before getting the immune checkpoint inhibitor, they've been treated with chemotherapy that may also trigger neuropathies. So some of the features that help differentiate between immune checkpoint inhibitor and chemotherapy-induced neuropathy is that with immune checkpoint inhibitors, it is more often non-length dependent, asymmetric, a more acute presentation, and demyelinating features on EMG. Sometimes the neuropathies may also mimic paraneoplastic syndromes with a sensory neuronopathy or with an enteric neuropathy, and they may have high-risk antibodies like ANA1 or CRIM5, and this tends to be more common in those patients who have neuroendocrine tumors. Another common neuromuscular complication is myositis. These are patients who typically, the first symptom is myalgia, and after that they develop muscle weakness. Typically affects the proximal limb muscles. It may also have prominent oculomotor and bulbar involvement, sometimes in isolation. Oftentimes, the CK is elevated in the hundreds or thousands, although it could be normal. These patients may have respiratory involvement, and a lot of these patients have also myocarditis. And when there is myocarditis and respiratory involvement, they have worse outcomes and about 20% mortality. And it may also overlap with myasthenia gravis. And this is known, and a lot of the patients have an overlap of myositis, myocarditis, and myasthenia gravis. This is what is called the triple M overlap syndrome, which can have a high mortality. One thing that is interesting is that there are many of these patients with myositis who have positive acetylcholine receptor antibodies, and that's why initially in the first cases they were thought to have myasthenia gravis. But sometimes these patients they don't have the typical findings of myasthenia when we do EMGs with repetitive nerve stimulation. So it is unclear whether in these cases the acetylcholine receptor antibody is pathogenic or whether it's just a bystander. And in these patients with myositis, the muscle biopsy typically shows clusters of necrotic fibers and also inflammatory changes. And then it may also affect the neuromuscular junction with myasthenia gravis. It could, in patients who have pre-existing myasthenia gravis, if they are treated with immune checkpoint inhibitors, it may flare up. But it has also been reported as new onset. These patients present with proximal weakness, oculobulbar weakness, fatigability, frequent respiratory failure, and as I said, oftentimes coexisting with myositis and myocarditis, and they have a high fatality rate. When we compare cases of myasthenia gravis after immune checkpoint inhibitors versus idiopathic, um, in those cases after immune checkpoint inhibitors, there is the association with myositis and myocarditis, which doesn't occur in spontaneous cases, and there is typically more severe, often present with myasthenic crisis. And then in terms of paraneoplastic, as I said, there are high-risk paraneoplastic syndromes that may occur after immune checkpoint inhibitors. There are studies that have shown that there's been an increase in the incidence of paraneoplastic syndrome since the immune checkpoint inhibitors were approved, including anti-MAT2 and anti-HU. But there are also other high-risk antibodies that have been reported, and also unclassified antibodies in patients who high-risk phenotypes like limbic encephalitis or opsoclonus myoclonus. This happens in about of all of the patients with neurological immune-related adverse events. About 15 to 20% is the percentage of patients who present with paraneoplastic syndromes, and they may occur also in malignancies that are not traditionally associated with spontaneous paraneoplastic syndromes like renal cell carcinoma. The clinical presentation is similar to the spontaneous paraneoplastic syndromes. More often affects the central nervous system with limbic encephalitis, a rapidly progressive cerebral syndrome, brainstem encephalitis. But there are also peripheral nervous system paraneoplastic syndromes like sensory neuronopathy and Lambert-Eaton syndrome. The prognosis is usually worse than with other neurological immune-related adverse events. And even though these patients tend to be treated more aggressively with immunosuppressants, they don't respond well to treatment, and they typically have high disability and mortality. And in these cases, there is less association with known non-neurological immune-related adverse events, which supports that it may have a different pathophysiology. There are some studies that have compared the paraneoplastic syndromes that occur after immune checkpoint inhibitors with spontaneous paraneoplastic syndromes. And usually spontaneous paraneoplastic syndromes occur in patients who have early malignancies, limited stage. But these patients who develop paraneoplastic syndromes after immune checkpoint inhibitors typically have more advanced malignancies. The clinical presentation is similar. And then in terms of outcomes, it seems that at least for the anti-HU patients, they seem to have worse outcomes in those cases that occur after immune checkpoint inhibitor treatment, and they have higher mortality, although perhaps that may be in part driven by the fact that these are patients with more advanced cancer, so they have poor status. And we also looked at it in our anti-HU cases, and we found that those that occurred after immune checkpoint inhibitor treatment, they more often had multifocal involvement with central and peripheral nervous system involvement when compared to the spontaneous cases. How about treatment with immune checkpoint inhibitors in patients who have pre-existing neurological autoimmunity? So these were so patients who had pre-existing autoimmune disorders were oftentimes excluded from the clinical trials that were done for immune checkpoint inhibitors. So this is something that we are still learning about. So it is really important to identify patients who have pre-existing neurological autoimmunity prior to starting immune checkpoint inhibitors because they could get worse. Um, but this is not a contraindication for treatment with immune checkpoint inhibitors. So, oftentimes when we are considering treatment with immune checkpoint inhibitors, these are patients who have advanced malignancies, limited treatment options. So we have to consider the risk and the benefit ratio on a case-by-case basis. And there is growing evidence in the literature. There are more and more case series reported of patients who had pre-existing autoimmune disorders. So, for example, for patients who had pre-existing myasthenia gravis, there are a couple of case series that show that there is actually a high rate of relapse of myasthenia gravis after treatment with immune checkpoint inhibitors. In one case, it was 85%, and in the other one was 67%. And oftentimes, these patients required hospitalization, and there were actually fatal cases. So, this is something that is really important to keep in mind. And there is also one case series of patients who had Guillain-Barré syndrome. And these patients actually tolerated immune checkpoint inhibitors well with no exacerbations, although there was one patient who developed Lambert-Eaton syndrome. And there are also several case series that have been published now in patients who had pre-existing multiple sclerosis or radiologically isolated syndrome and were treated with immune checkpoint inhibitors for cancer treatment. Most of these patients were older individuals who had inactive MS for many years, right? So this just represents the demographics of the patients who are treated with immune checkpoint inhibitors, usually patients who are 50s, 60s, 70s. So by then, these patients who have had MS, usually for many years, they have inactive MS. Oftentimes, they've been off disease-modifying therapies for some time. So in these patients, really the risk of developing new MRI lesions or MS relapses after immune checkpoint inhibitors is low. And in the case series, when the patients who developed inflammatory activity were patients who had radiologically isolated syndrome, patients who were younger, usually less than 50 years old. And it has also been described in patients who discontinued their disease-modifying therapy right before they started the immune checkpoint inhibitor, particularly natalizumab, which we know is a treatment that when we stop natalizumab in patients with MS, there is a risk for return of the inflammatory activity or rebound. So based on this data, multiple sclerosis should not be considered a contraindication for immune checkpoint inhibitor treatment, particularly in those patients who have a stable MS. It's important to assess what is the activity of MS before starting immune checkpoint inhibitors and consider continuation of disease-modifying therapy at the same time that the patient is receiving immune checkpoint inhibitor in some cases, those patients who are younger or who have more active MS. And it's important to monitor these patients closely clinically and radiologically after starting immune checkpoint inhibitors. And how about patients who had pre-existing paraneoplastic neurologic syndromes? So several case series have reported that patients who had pre-existing paraneoplastic syndromes had irreversible neurological worsening after they were treated with immune checkpoint inhibitors. So in these cases, it really has to be an individualized decision, depending, again, what is the risk and what is the benefit? What do the patients have any other options to treat their malignancies? And as I mentioned before, there are some of these patients who developed paraneoplastic syndromes after treatment with immune checkpoint inhibitors who, when they checked their blood for antibodies before they were treated with immune checkpoint inhibitors, they found that some of them already had high-risk antibodies in blood. So, there is this question about should we be testing neural antibodies in these patients before starting immune checkpoint inhibitors, particularly in those patients who have malignancies that are usually associated with paraneoplastic syndrome, such as, for example, small cell lung cancer. And we don't have a good answer to this yet. It's definitely a good research question, but as of right now, we do not think that we should exclude these patients who have neural antibodies but who have never had any neurological symptoms. We don't think that we should exclude them from treatment with immune checkpoint inhibitors. In terms of the diagnostic and treatment approach, so we have to consider neurological immune-related adverse events in any patient who presents with subacute onset neurologic symptoms after treatment with immune checkpoint inhibitors. When we are talking about a central nervous system syndrome, we are typically going to do MRIs of the brain and the spine, although in some cases they may be normal. But the MRI is really important because it's going to help us also exclude metastases, evaluate for leptomeningeal disease. We're also going to do a spinal fluid analysis, which again is frequently abnormal with pleocytosis, but it's important to rule out infections and carcinomatous meningitis, particularly in those patients who present with meningitis or meningoencephalitis. And then we are also going to evaluate for neural antibodies in the blood and the spinal fluid. For the patients presenting with peripheral nervous system syndromes, if they are presenting with a neuropathy, we're going to do an EMG. We're going to do a spinal fluid analysis looking for pleocytosis or albuminocytologic dissociation. And typically, we're also going to do MRI of the lumbar spine to look for that gadolinium enhancement of the coraquana roots. Sometimes we may consider MRI of the plexus depending on the presentation. And for the patients who present with myositis or neuromuscular junction disorders, we are also going to do EMG. Very important to check the CK. We are going to check the acetylcholine receptor antibodies. We can also check the antibodies that are associated with myositis, although actually most of these patients are negative. These patients with myositis after immune checkpoint inhibitors, most of these patients are antibody negative. We may consider doing an MRI of the affected muscles. Very, very important in these patients with myositis or neuromuscular junction disorders, always check troponins because of the high association with myocarditis. We may even need to do an echocardiogram, and we could also consider doing muscle biopsy. And really, in all of these cases, we always have to keep in mind that we have to exclude alternative etiologies, that patients with cancer may have other reasons to have neurological symptoms. So we always have to exclude dissemination of the cancer, infections, metabolic complications, and adverse events from radiation therapy or chemotherapy. In terms of treatment, so there are a number of different guidelines for treatment of these patients from the Society for Immunotherapy of Cancer, the American Society of Clinical Oncology, the National Cancer Centers Network. And usually these guidelines, what they do is that they classify the toxicities based on their severity grade, going from grade 1, which is asymptomatic or mild, to grade 4, which is life-threatening. And they give recommendations for each of these syndromes. In general, these are some general principles for treatment. So we are typically going to discontinue the immune checkpoint inhibitors when the patient presents. And the first line of treatment is going to be steroids. We are going to use IV steroids when the patients have moderate to severe symptoms. But patients with mild symptoms, we may do oral prednisone. And in cases of meningitis or mild neuropathy, this may be enough for the patients to get better or even have resolution of the symptoms. However, in cases of myositis, myasthenia gravis, polyradicular neuropathy, encephalitis, those are patients that have more severe presentation. And usually, in addition to steroids, they may need IVIG or even plasma change. In patients with myasthenia gravis, there are some studies that suggest that use of IVIG or plasma change as first line may be associated with better outcomes. And if there is no improvement after this first line of treatment, we consider escalation to rituximab or cyclophosphamide. And in those patients who present with paraneoplastic syndromes, we usually start rituximab or cyclophosphamide early. There are a number of other agents that have been used in case reports. There are some case reports of eculizumab being used in immune checkpoint inhibitor triggered myasthenia gravis, cases of natalizumab used in encephalitis. And the advantage of natalizumab is that it doesn't interfere with the immune checkpoint inhibitor anti-tumor response. So this is always a concern when we are giving immunosuppressants to these patients, is that we are going to affect the outcomes of the tumors. So the advantage of the natalizumab is because of its mechanism of action. It doesn't really affect the anti-tumor response. And similarly, it's thought that tocilizumab, which is an anti-IL-6 agent, also wouldn't have that effect on the anti-tumor response. And this is being increasingly used in patients, particularly those who have high IL-6 levels in the spinal fluid, although the results reported are mixed, but it's been used in myelitis and encephalitis. How about once the patients have recovered or improved, can we treat them with immune checkpoint inhibitors again if they need it for their cancer? So this is a question that also has to be answered on a case-by-case basis. These are advanced malignancies that have limited treatment options, and actually the main cause of death in these patients is cancer progression. There is variability among the case series that reported rechallenge in patients who develop neurological immune-related adverse events. Some case series have reported low frequency of relapses. Others have reported that in those patients with severe immune-related adverse events, grade 3 or more, half of the patients have relapses when they are rechallenged. So in general, we think it's reasonable to try rechallenge in those patients who have low severity neurological immune-related adverse events, who have responded well to treatment, like meningitis, mild neuropathy. But it's generally avoided in those patients who have severe neurological complications, particularly in those who developed high-risk paraneoplastic syndromes, because usually these patients tend to develop relapses with irreversible worsening. How about the outcomes and the prognostic factors? So there are a couple of big case areas that have been reported looking at the outcomes, mortality, and prognostic factors. This was a case series of 147 patients with neurological immune-related adverse events, and they reported the outcomes at a median of 14 months, and 66% of them had minor disability. And these patients who had better outcomes, those were who had developed myositis or neuromuscular junction disorders, polyradicular neuropathy, cranial neuropathies, meningoencephalitis, meningitis. It is important to note that those patients who developed myositis and neuromuscular junction disorders have high mortality acutely. However, those who survive, it seems that the risk of long-term disability is relatively low. And then usually the outcomes are worse with severe disability in those patients who have myelitis, cerebral ataxia, sensory neuronopathy, limbic encephalitis. So those patients will have more of a paraneoplastic-like syndrome. In terms of prognostic factors, there are a number of factors that have been reported to be associated with poor outcomes in different case series, including having lung cancer, a higher severity grade at onset, being older than 70, having central nervous system involvement versus peripheral nervous system involvement, having focal encephalitis versus meningoencephalitis, having positive neural antibodies, particularly those high-risk paraneoplastic like syndromes, and also the lack of other systemic ICA-related autoimmunity. In terms of mortality, so in these large case series, in one of them, there was a 33% mortality, 35% of them due to cancer progression, and 31% of them because of neurological immune-related adverse events. Uh, Usually, neurological toxicity leads to death in the first 3 months and cancer progression after 3 months. And then in the other case series, there were 42% cases of patients who died, half of them because of cancer progression, and a little bit less than half because of neurological immune-related adverse events. And factors that predicted mortality were that subtype of encephalopathy without evidence of inflammation that I mentioned earlier, lung cancer, and having the triple M overlap syndrome with myocarditis, myasthenia, and myositis. So to conclude, the neurological immune-related complications are increasingly recognized. These can potentially improve with immunosuppression. The outcomes depend on the clinical phenotype, age, and the underlying cancer. Paraneoplastic syndromes triggered by immune checkpoint inhibitors may occur, and they are associated with higher disability and mortality. Having a pre-existing autoimmune neurological disorder is not an absolute contraindication for immune checkpoint inhibitor treatment, and immune checkpoint inhibitor rechallenge needs to be discussed on a case-by-case basis. Okay, and now we are going to start with the cases. Oh, Meg, I think that you are muted.
Thank
Oh,
you.
yeah.
I'm going to go ahead and stop the recording.
Okay.
And that way, if there's any questions or discussion to go with this, we can have everybody feel comfortable with that.
Okay.